our dear friend uh, is actually back joining us on VMR. Kirtan, for those who haven't met you, can you tell them a little bit about yourself?
Hello, friends. Good morning, good afternoon, and good evening to everyone who are joining us from different parts of the world. And thank you for joining us on this Friday VMR. And yes, so my name is Kirtan Patolia. So I am originally from India. I completed my med school there. Then I am currently working as the first year internal medicine resident here in Chicago at John H. Stroger Hospital of Cook County. And it's always a pleasure to be here and share the clinical reasoning with you. And sometimes, when you present the case, it's not just that you are giving other a chance to learn from your case. You actually learn from their thinking, from the thinking in the chat, that how different ways we can approach the same problem and can get to the diagnosis and manage it in the effective manner. So please share your thoughts in the chat as always. And we have with us Ravi and all my dear friends here to help us, and looking forward to today's session. Thank you.
Kirtan, it's so nice to have you back. Kirtan is a VMR legend for those of you who don't know him, and is very busy in intern year, but thrilled to have him back. For those of you who have your videos on, it's really nice. Thank you. I wanted to introduce you all to a new, she doesn't know this is coming, a new VMR joinee, and her name is Beatrice. I don't know if you see her. Bia, do you have a minute to unmute and introduce yourself to the crowd?
Hi everyone. I'm so enthusiastic to be with you today, but yesterday was actually my first day here, and I'm an Italian student, and actually I'm currently in my 5th year, because in Italy it's a 6-year degree program. And my interests are computational neuroscience and neuroscience in general, and my dreams would be those of pursuing a PhD in computational neuroscience and eventually a residency in psychiatry, and both of them hopefully in the States. And I'll be there actually next year in Boston, so I hope to meet someone from this community. And thank you for everything, because for me it's an opportunity, like an enormous opportunity, both of learning and both of feeling part of a community. So thank you very much.
Welcome. There's a lot of love for you in the chat. You should totally take a look. And I see Caitlin's back. Caitlin is here too. Andy's here. What's up, folks? And of course, the one and only Jazz.
I'm in Pisa just today, but I'm doing also an Erasmus program. So like in 2 days, I'll be in France, because I'm doing an exchange program for a year, and that's it. Okay, I'll mute myself and I'll let you.
Welcome.
Thank you.
Yeah, it's so nice to see so many familiar faces. Jazz is back, Hans is here, Caitlin's around, Andy's back, and I also just saw that Ria, who I haven't seen for a while, is also joining us. So welcome everybody. The only downside today, unfortunately, is that Prof. Rez is a little bit under the weather, so can't make it today. And I am actually in the middle of an ER shift, so we'll see how this goes. But Kirtan has a case for us, and the goal for today is actually a little bit different than it usually is. I'd encourage you all to do whatever you feel like, but for me, I'm going to try to pretend that this is a patient that I'm taking care of. And so in VMR, we often elaborate and think more than we would in real life because we have the time to. But I will just pretend this whatever data data that Kirtan shares with me will be no different than if I were taking care of a patient here. So it'll be more focused and more realistic, I think, just to try to mix things up. So without further delay, Kirtan, take it away, please.
Sure. So the title of today's case is A Mysterious Turn of Events, and it's a short and sweet case. So
Amazing.
So
I will say that if a patient came to me and they said the title is the short and mysterious case, yes, I'd be very intrigued and very interested in why they said that to me.
I know.
Thank you for the little clue.
Yes. So the first aliquot is, we have a 27-year-old gentleman with no relevant past medical history who comes in with 5 days of persistent fevers, headaches, nausea, vomiting, sore throat, neck and shoulder pain, and diffuse body aches. So lots of constitutional symptoms. Upon initial evaluation, he was found to be febrile at 38.4 degrees Celsius, tachycardic at 130 beats per minute. His blood pressure was within the normal limits at 126/82 millimeters of mercury, and he was breathing at the rate of 18 breaths per minute and saturating at 98% on room air. And this is the end of fossil.
Yeah, thank you, Kirtan. I think this is not an uncommon scenario in that a patient has a fever and fever is assumed to be infectious, and the infection is then the hunt is on for the specific infection. Most of the time, we have the luxury for the infectious disease process coalescing or localizing to a specific organ. And here, that's not the case. Here, the patient has such diffuse symptoms that our job is to try to figure out, well, which of these symptoms is the most diagnostically helpful? And that comes with practice. I would argue here the most diagnostically specific sign is the presence of pharyngitis. And the intriguing dimension of patients with pharyngitis is that most patients with pharyngitis do not have a systemic signature. They have a sore throat and that's it. So I would be simply calling this problem as a pharyngitis with systemic features and with markers of acute severity, namely the tachycardia. Now, we don't know if the tachycardia is sinus or not, but I would initially say this is probably looking like a really bad infectious pharyngitis. And so what that does for me is it immediately makes me want to check for COVID, influenza, and RSV to consider pyogenic infections, like namely group A strep as the biggest one. But I think I would go beyond that in this case based on how sick the patient appears to be. And going beyond that also includes going beyond and thinking about other organisms, but also to make sure the patient hasn't suffered any pyogenic complications. And those complications may be a peritonsillar abscess or retropharyngeal abscess, Ludwig's angina, Lemire's syndrome, things like that. So I think what would happen in this patient is they would get fluids, they would get swabbed for group A strep and for viruses, and we would do a careful exam to make sure we're not missing a pus pocket behind the throat, underneath the mouth, or on the sides.
Excellent thoughts, Rabi. And even in the chat, people have summarized it very well. Could this be paratonsillar abscess, retropharyngeal abscess? Then just Deep shared if this could be, jugular and thrombophlebitis. Nilan shared if this could be mononucleosis. So all of these are excellent thoughts, and this is what we were thinking at that moment in time. So moving to the second aliquot, as far as the past medical history, family history, medications, and social history is concerned, everything is not relevant. Patient doesn't have the smoking, alcohol, no illicit drug use. Patient was roaming on the streets, doing his job, coming back to the hospital, nothing out of ordinary, no travels. And in the examination, the only remarkable finding was that the patient had mild splenomegaly and diffuse tenderness to palpation of the abdomen. And as per the referring hospital records, his monospot test was positive. So basically, patient went to another hospital. Before that hospital referred that patient to our hospital. And giving you a little bit of basic labs. So hemoglobin was 14.2 within the normal range. The white blood cell were low. So it was 2.7. And over the course of the hospital admission, it kept on going down with the lowest levels being 1.8. Same was true for platelets with lowest levels being 30,000. So there were low platelets and low WBC, normal hemoglobin. The AST levels were elevated at 98. And over the course of hospitalization, they kept on rising and peaked at 474. The ALT levels peaked at 272. The gamma glutamate transferase levels were 64 on admission and then peaked at 135. Same was true for alkaline phosphatase. They were 132 on admission and peaked at 187. The total bilirubin was 2.2, with direct fraction being 0.5. And LDH was elevated at 1,496 and it peaked at 3,000 over the course of hospital admission. And that's the end of secondary.
Yeah, Kirtan, I think that with this data that you're providing us, I think that we're realizing that the disease is not just localized to the pharynx, that it is a systemic disease with pharyngeal involvement. And whenever we're thinking about infection plus splenomegaly usually means either mononucleosis virus, a tick-borne virus, or a granulomatous infection. So the question is, which of those are compatible with this case? And I'd say that at first glance, only really mononucleosis is compatible with pharyngitis splenomegaly. However, the presence of leukopenia changes that calculus. because leukopenia is a very unusual finding in patients with infectious mononucleosis, even if their monospot is negative. So what infections are compatible with leukopenia and splenomegaly? It really is tick-borne diseases. So that's a possibility, although that occurring in the dead of winter in Chicago is extremely unusual unless this patient is has presented earlier than that. So the question is, well, how do we approach the leukopenia in general? Because it's clearly changing our case a lot. And the diagnostic specificity of leukopenia is not that high because it's seen as part of sepsis of any kind of infection. But if it is a marker of specificity, again, it can be seen in tick-borne infections. It's commonly seen in certain autoimmune diseases, namely lupus and Kikuchi-Fujimoto disease. And those would be the most important acute considerations. However, in a young person with fever, splenomegaly, and cytopenias, you have to start thinking about HLH or hemophagocytic lymphohistiocytosis, which in this patient may be either primary or secondary because of his young age. So this could be a case where you have data that suggests that this person has acute mononucleosis. He has pharyngitis, splenomegaly, awesome. Our patient's troponin is negative. Thank you, Nicole. Woohoo! Thank you. And so you could say, hey, this person has mono, pharyngitis, splenomegaly, and then you could say the leukopenia is because this is a person who's young and developed HLH as a result of acute mononucleosis syndrome. So what would I do next? I think the most important tests in this patient are tests for mono that are more specific than the monospot. So it's EBV serologies, CMV, and HIV serologies. And I think that sending off a TSH for the possibility that this is hyperthyroidism presenting as pharyngitis and systemic symptoms is not a bad idea. And then doing the simple stuff, making sure this is not acute viral hepatitis, followed by imaging of the abdomen and pelvis to really look for whether or not there is lymphadenopathy. And then finally, to bolster the case for HLH, you might look for a ferritin to see if the ferritin is very high. All right, Mike, to you.
Perfect. You guys almost got the case. And so I just wanted to iterate one point that when we think about mononucleosis like illness, it's often, nice to take a step back and realize that what else it could be, which looks like mono. So something known as IMLS, like infectious mononucleosis-like syndrome. And many of those disorders are what you mentioned. It could be CMV, and Dr. Singh mentioned that it could be HIV, acute retroviral syndrome, must not miss, and things like toxoplasmosis, measles, rubella, and Kikuchi disease, sometimes even Bartonella, Brucella can present like this. Then rarely some lymphomas like angioimmunoblastic T-cell lymphomas, Castleman disease presence like infection mononucleosis, so always keep an eye out for them. So talking about the thyroid studies, we obtained them and they were within the normal range. For the imaging, the CXR, like there is a chest X-ray and CT thorax was unremarkable. CT abdomen and pelvis were unremarkable except for the mild splenomegaly. And extensive infectious and autoimmune workup done, including the CSF cultures, because patient came in with this vital signs suggestive of sepsis-like picture. Patient had terrible headaches, so we obtained the CSF studies as well. Blood cultures, serum fungal cultures, urine histoplasma, HIV, CMV, hepatitis panel, herpes simplex virus, COVID, adenovirus, influenza, parainfluenza, respiratory syncytial virus, human metapneumovirus, ANA, ANCA, and cryoglobulins, all of them were within the normal range. And over the course of hospital admission, the only thing which changed was that although the lab findings were kind of worsening, so pancytopenia kind of set in, the transaminitis was worsening, the LDH was going high, and the symptom-wise, patient's abdominal pain kind of went away on its own. We didn't even give Tylenol and it just went away within a day or two. But the headaches, so headaches became the chief complaint now. So every day we will go and examine the patient and the patient will say that I have 10 out of 10 headache. We tried so many other analgesics, so many other maneuvers and measures, but nothing helped. So that was the part where we were thinking that what else could this be? And at this point, I would like to ask you that what additional studies you would like to obtain before I reveal the final diagnosis and final set of data.
I think, Kirtan, it's amazing when there's a discrepancy in part of the disease process, you have to step back. And I'm glad the abdominal pain is getting better, but the labs are getting worse and the headache is getting worse. And the question is, what do you do about a headache What does the headache signify? And whenever you're getting such prominent systemic findings, it's easy to think that the headache is part of a systemic disease. But I think whenever you have a headache in a patient who's thrombocytopenic, you have to make sure that there isn't bleeding in the CNS. And so that would be, I think, the first priority. However, when you have fever and a refractory headache, you have to make sure that you're not dealing with an infection within the brain, which it can be a brain abscess, it could be, or it could be meningoencephalitis. So you gave us some of that workup, and you told us the CSF studies were negative, meaning the lumbar puncture is negative. And so you'd probably be wondering, is there, since the meninges are been assessed and negative, you would wonder if there's a structural lesion in the brain. However, it's also not uncommon for systemic infections to cause a headache, like mononucleosis. So I think progressive cytopenias, progressive liver injury, despite improvement, is a good case for HLH. The overlap between HLH and headache could simply be neurologic involvement of that disease process, or it could signify a simple complication like a hemorrhage. So I think, what would I do next? I think you really want to just make sure you're not making any assumptions. So you would want to know the mechanism of the pancytopenia. Is it bone marrow suppression, or is it destruction with hemolysis? You want to make sure that you have sent off viral serologies, and you want to make sure you check out the simples. So make sure that there's no intracranial hemorrhage, for example. And I think the test that might be very, very informative is getting a ferritin level to reinforce whether or not we're on the right train with HLH or not. That's what I would do.
Sure. Excellent, guys. So as you mentioned, firstly, we obtained the EBV serologies to clarify that whether this is indeed mononucleosis. So EBV viral capsid antigen IgG levels were over 750, but the IgM viral capsid antibodies were negative. And EBV...
One second.
Yeah, it's fine. And the EBV nuclear antigen IgG was negative, but the EBV DNA quantitative PCR returned elevated at about 51,000 copies with 4.7 log copies per ml. So all in all, the EBV quantitative PCR was very, very elevated, suggestive of acute infection. The triglycerides were elevated at 249 and they peaked at 331. And the ferritin levels were above 7,500. So that's the limit beyond which our laboratory can't measure the ferritin. So it was very high. The prothrombin time was 16.9. The INR was 1.41 and APGT was 40.3 and D-dimer more than 20. So all of those things, coagulation markers were deranged. And as Rabi mentioned initially, that if we want to simplify everything, that this could just mean that this is CNS HLH kind of picture. So how does HLH usually comes into the brain part? So there is one way in which HLH can explain the headaches, and that is actually the posterior reversible encephalopathy syndrome kind of stuff, because it has been postulated that because of the intense inflammation, the blood-brain barrier gets disrupted. And as we know that usually the posterior circulation is the part where the barrier is the weakest. And that's why you tend to get this extravasation of the fluid and you get the vasogenic edema, and that's why you can get the headaches. And often the blood pressure is normal. So we have this thinking that if the blood pressure is elevated, then only we get like this headache. And that is true, but that is more likely in preeclampsia and eclampsia kind of pathologies. But in like the medicine world, often it happens that blood pressure is normal and it's just the disruption of the blood-brain barrier which causes these headaches. So our colleagues thought that could this be press related to HLH, but eventually they thought that we don't need to get MRI for that. We can just try to control the HLH and then we can see if the headache is improving. If it doesn't improve, then we can go for it. Meanwhile, we obtained the CT scan to rule out subarachnoid hemorrhage or intracranial hemorrhage or any other concerning findings like cerebral venous sinus thrombosis, which were unrevealing. And due to the persistent deterioration of his clinical condition, he was started on ganciclovir. So this was, kind of a twist. That's why I wanted to present this case, that usually HLH is so fulminant that we want to treat upfront with like high dose IV steroids, sometimes even etoposide, which is like chemotherapeutic agent. But there have been studies which shows that if you have infection, especially the viral infection. And if you try to treat it with antiviral agents, then sometimes it can help. So that's what we did. We gave the ganciclovir, and within 3 days, there was effervescence of fevers, improvement in labs. Patient was no longer pancytopenic. The liver functions were downtrending. The ferritin came back to like 2000 from above 7500. The coagulation parameters kept on improving. And ultimately, the bone marrow biopsy, which was obtained while the patient was still sick, revealed the evidence of increased monocytes and macrophages with hemophagocytosis. And about a month later, the soluble interleukin 2 receptors came back, because like those tests take so much time that patient will go out of the hospital for sure before the results come back. So they came back eventually, and they were elevated at 35,000 picograms per milliliter, which is like super high. So he was ultimately diagnosed with HLH with an H score of 228, and headaches were thought to be due to press, because they eventually improved once we gave the ganciclovir. And that's how the case was concluded. So like Ravi got it, like in the middle of a busy shift, he got the diagnosis, and all of you guys in the chat also got it very quickly, that could this be mono? Could this be pancytopenia? Could mean HLH. So kudos to you guys. It was very nice.
Kirtan, I can't believe you presented a case of HLH in 15 minutes. I think that is, it is probably a world record, honestly. Thank you so much for such dense education. And the truth is that if you're hopping on VMR for the first time or relatively new, this is probably overwhelming, and it is overwhelming in real life. And I think whenever you're making it so far down the depths of medicine, you want to make sure that you understand the early steps. And I think the early steps here are actually very simple, and it gets very complicated, and there's a lot of nuance. So what are the early steps? Whenever somebody has a systemic syndrome, try to spend some time asking yourself, what is the most helpful feature? And solving this case as a pharyngitis was really important, because if you just started and said headache, or you said neck pain or shoulder pain or body aches, your destination, your journey would have been much longer to suspecting mononucleosis. So the first step was actually saying, hey, I think this is pharyngitis. And when you think pharyngitis, you immediately start to think, well, what's my approach to infectious pharyngitis? And that's actually very simple. There's common viral causes and common bacterial causes. COVID, influenza, mono, and mono-like diseases. Bacterial causes, group A strep, and sexually transmitted infections like syphilis, gonorrhea, chlamydia. Simple. And so then when you see that the patient has a fever, has splenomegaly, you're like, well, it has to be mono. What else causes in a young person pharyngitis, fevers, and splenomegaly? And then it becomes tricky. Why would mono cause a leukopenia? And that is a fascinating set of circumstances that have to do with the fact that this patient does not respond well to certain kinds of infections. At his age, at 27, he almost certainly has genetic HLH, which is a disease process that is essentially impairment of his immune system to stop revving up. It's basically often a deficiency in the Fas ligand. So he, unlike most people, will get this hyper exuberant reaction to mononucleosis, where his body is attacked by a virus, but for some reason his body goes berserk, crazy, doesn't stop. And that causes more cytopenias, more problems, and you have to immediately treat the infection. So you can learn and read more about HLH, but I think the thing to try to push yourself is, I'm convinced this person is mono. How can mono cause leukopenia? How can mono get worse in a patient? And there's only one answer, HLH. There's nothing else that causes mono and leukopenia with worsening except HLH and some other kinds of immunological issues that can turn the mono into a cancer right away. So I think that's the core learning in this case. Thank you, Kirtan. What did you take away from this?
Sure. So thank you for, beautiful cut down and breakdown of like how we can approach the case. And I would just like to iterate what Rabi said, that sometimes when you come on VMR and sometimes in the world of medical journals, often you find that, HLH is like relatively common. You find it you immediately start suspecting as long as the ferritin levels are high, the triglyceride levels are high. But the key is to think ahead of time. Like let's say if we just have a patient with fever, tachycardia, and all these sore throat and constitutional symptoms, and if you think at that point in time that, well, could this transpire into HLH? And based on that, if you order the test, then when it's become interesting, because if you have ferritin, then you know that there is no mystery left. So I guess thinking ahead of time is something which I learned from this case. And Jack Banner, our dear friend, shared this with me long time back, that all the brilliant diagnosticians like, Dr. Gurpreet, Daliwa, Rabi, Reza, why they are so good and why it's so elegant to listen to their clinical reasoning, because they are 2 steps ahead of us. Like just with the headache and sore throat, we were like, okay, this could be mono, this could be group A beta step. But what it could lead to? Could it lead to DIC? Could it lead to retropharyngeal abscess? And could it lead to HLH? So having that thought process ahead of time kind of helped us. So that's why in this case, actually, before we sent the ferritin, already we had thought about, okay, could this be HLH? Could this be this? Could this be that? And then when the ferritin came, our suspicion kind of went ahead and ahead and ahead. And last thing, anchoring bias, that Rabi very beautifully mentioned, that headaches. Now, how to explain the headaches? Should we go down the another route and forget about HLH and EBV, or should we try to explore whether HLH can explain the headaches before jumping to something else? And as it turns out, it was indeed due to HLH. We never had to look ahead of that, because we ruled out the infections, the most morbid condition. We ruled out the hemorrhage, again, most morbid condition. And then at the end, what was left was the truth, that it could be pressed because of the HLH, because there has been strong reports, strong association between that, and the characteristic of the headache with the patient had kind of fits with that. So that's how it is. And the most important part, that prednisone, sometimes we try to give it too often to people with HLH, and rightfully so, because HLH is so exuberant that you don't want to hold back the prednisone, hoping that it would improve on its own, because most of the times people with HLH cannot make it, unfortunately. But this case was, kind of unique, because we never kind of figured out that why patient improved so rapidly within just 3 days of ganciclovir. Like, was it just a course of EBV infection that it was supposed to resolve on its own in 7 days? Or it's just that maybe the antiviral therapy which we gave kind of hastened that process. That's it. But we never gave prednisone, not even 1 dose of prednisone. So that was kind of, unique, because HLH, you think that ganciclovir won't be enough, but it was enough in our case, fortunately. So that's how it was. So thank you again for giving me the opportunity to present the case. Learned a lot. We'll read that paper which was shared in the chat. Thank you for sharing that. And now, Deborah, please take us home.
Hi, everyone. Thank you for the case. Great discussion, Ravi. I tried to keep up some thinking points here, and then with the chief complaint of fever, we think about could be an infection, and then the patient have systemic factors. So we think about checking for COVID, some virus like influenza, RSV, and don't forget like to check for the complications for pharyngitis, and then we thought about infection plus the splenomegaly. That could be a granulomatosis and a mononucleosis infection, but Ravi said that leukopenia could not be usual it's unusual for mononucleosis. And in this case, we thought that could be not just mono, but maybe an acute retroviral infection, could be maybe a hypothyroidism. So don't forget to check all this for all this disease. And the headache in this case was refractory. So we thought could be something in the brain, a brain abscess and meningoencephalitis. And going for the HLH, it's like a systemic multi-organ of the hyperinflammatory state, and could be primary, like for genetic, or secondary, probably from an infection, and has like 5 criteria of 8 clinical diagnosis. And yeah, in the end, we thought that going back for the beginning of the presentation, looking for first for the pharyngitis, and then we add the fever, splenomegaly, and the leukopenia could be explained by the genetic HLH. And yeah, I think that's it. Thank you everyone for being here today. I see you all in next year.
Oh, Deborah, we have had a treat of having Deborah do back-to-back teaching points, which is a delight. I don't know if Kirtan mentioned this out loud, but he's on vacation for 15 days. And so we are likely to revel in his glory. It'll be a lot of fun. Thank you, Kirtan, for joining us. It was really nice to see you and to see all of you. Happy Friday. And like Deborah said, Happy New Year. We hope to see you happier and wiser and deeply entrenched in this very loving community. Bye.